Hello. So today I'm going to show you how to record in our EMR, which is Practice Fusion, a new patient. And in that, we will show you how to record the history of the chief complaint, history of the present illness, and also record his medications, his diagnosis, and then the objective, which is the exam assessment, which is includes all the diagnoses that we have found or we suspect, and then the treatment plan, which is the end of the plan. So I will show you on our in a shared screen how this all works. So let's say there's a new patient. Our experimental patient or our demonstration patient is Don Lee, and we use him so that we don't have to put these rough notes against anybody. So I'm going to pull up first of all the Practice Fusion program. So let's see. Let me share the screen. Share the screen. Okay, there we go. So the screen is now shared. And this is the Practice Fusion. And we're going to pull up the patient, Mr. Don Lee. So you go to the charts and you put down, I've already pulled him up actually, he's Don Lee. And let's say you forget about the fact that he has all these encounters, which were all for teaching purposes, but let's say he's new, so there will be no encounters here when he's new. We have to start all over as a new patient. There will be zero here, nothing, and nothing on the medication, nothing on all these diagnoses. All will be blank. So you create a new encounters for SOAP, SOAP, Subjective Objective Assessment Plan, as you know. Click on New Encounter, and here is a new encounter. Now, the first thing that you do is identify the patient. Is this right patient? Date of birth, age, if you want to see, and that is today's visit. The date is here, and it's today. And this is very important because people forget this. Seen by, it will always be my name because there's only one doctor that you have to deal with. Facility is the same, so this will be both the same. Amin Karim practice and seen by, not all these other students and other research people and everybody is listed here, are medical assistants, but I'm the one who is responsible ultimately for the patient. Therefore, it's my name. And the reason is because if it is my name here, then it falls into my inbox for me to complete the history and sign the chart off. If my name is not here, it won't fall and I have to search it and then bring it into my box. So if you can do me a favor and make sure that the name is there so that it will fall in my box. So that's easy. Now, let's start with let's say you have seen the patient, talked to the patient, and you put down jot your little notes on the piece of paper that you carry with you in the room. We have a system where we write down on a piece of paper whatever we see in the room, and don't carry a laptop or a tablet with us, because I feel that that's intruding on attention that we give to the patient. You're not able to look at the patient in the eye, and we're looking at the computer all the time. I see it in many other doctors, almost a lot of doctors do now, who have EMR, they just go with a little laptop and are busy clicking on the laptop and paying less attention to the patient or examining the patient. So you take down your notes on a piece of paper, and then when you sit down to write the note, this is what brings you to this chart. So you have opened this encounter, and all these details are here: encounter type, SOAP type, chief complaint. The next, you record the chief complaint. So in the chief complaint, you write down whatever you want: chest pain, if the patient came with chest pain, which is what we see most of the time, or shortness of breath, whatever it is, but just one complaint should be here. Sometimes you can write down two if you want, but mostly it's one. Now, the flow sheets, I don't usually do that because all these growth charts and all go to the vitals, and the vitals would have been recorded. If not, then you record it here. You write down the patient's height, weight, BMI is automatically calculated, the blood pressure, temperature, pulse, and respiratory rate. So you put that on there, and this is usually from the sign-in sheet or from the progress note sheet that we have on the chart that you are using to write your notes. On the top of it, these things will be mentioned. So having done that, then you go to the diagnosis, which you leave it now because this will be populated once you are doing your assessment. There, when you record those diagnoses, they will automatically populate here. Now, remember, we are assuming this is a new patient, so none of these will be visible to you. Allergies, also when you do the histophysical, when you do the exam, but you can record your allergies here. If you know the allergies of the patient, you can record, go to record, and you can record your allergies over here, select. Record drug allergies here. Drug allergies, you can say penicillin. So it will automatically bring up penicillins. Severity was, you should have asked the patient whether it was mild, moderate, or severe. Let's say it's moderate. What kind of reaction? Anaphylaxis. Okay. Onset was in childhood. You don't have to really write the date when it happened and all that if you don't know. And if it is active, just it defaults to active. And then of course you save it, and it will show as, you can see the drug allergies, penicillin, and it shows as moderate. And then of course aspirin somebody has added on before. Food allergies can be recorded, environmental allergies can be recorded, medications. So from the patient's questionnaire that he has filled out, you can record the medications. So you can say record. Let's say patient is on amlodipine in addition to the losartan that he is on. So amlodipine, and it will search it for you. Amlodipine 5, 2.5, 10 milligram tablet, and you can write down, since you don't know when it was started, if you know it, fine. If not, don't have to do all that. Just write down once a day, 1 tablet by mouth daily, and you record it here. So this will show up in the patient's medications. Now, social history. It doesn't say anything there. It just says print the social history, which is, you record this in your main narrative that you will be writing. When you bring the template for the history, the social history is there, you can just record it there. It doesn't have to be in a structured form, so that's why they don't have it as a record. Smoking status, yes, you can do that. He's a non-smoker, ex-smoker, whatever. Okay. Gender identity, don't have to do it, but you can, if you want, you can do it. They're not particular about that. Don't even ask about sexual orientation and all that. I want you to just bypass that. Since we are cardiology office and may not have to worry about what the sexual orientation is. Past medical history again is, it will come in the template, so don't have to record anything here. But let's see what it says here. In the record, you can enter major events. So if you want, you can do that here. So there's no problem. Then you don't have to do it in the template. So major events, CABG, coronary bypass surgery. If you have the year and then ongoing medical problems, you can do all that. So, and then comes a note. Now this is where I bring my template in the subject is, then you go to, let me see here, go here and go to subject. And you say record. That will bring out the template column in the middle, and the result, whatever you write, will come over here. So in the template column, it opens up a lot of templates, and you go to my template. So you just go back here because I'd opened up the echo template earlier on. These are the main headings of the template, and you are only interested in, we have two kinds of new patients. One is a cardiovascular consultation, one is a disability consultation. I don't do general internal medicine usually. So most of my patients are coming in for cardiovascular consultation. One patient a day, maybe 2 or 3 a week, come in for disability evaluation for the state of Texas. And that one will be recorded as new patient history and physical. So remember now, cardiovascular most of the time will be under cardiovascular consultation, disability evaluation under new patient history and physical. So let's open up cardiovascular consultation. So, and see what the template says here. So this is this template, okay? Here, all you have to do is, all these are already included here. All these are written here. You have to just say add all. So I don't know, this thing came in as add all, okay. I'm sorry, I shouldn't have done that. So let's go back. This is not what I expected because it's giving me all in one without having any divisions. So let's forget that. We will do it one by one. So patient comes in for cardiovascular consultation, right? Second will be history of the present illness, where you write down whatever you found in the patient's history. Patient is a such and such year-old person who comes in for cardiovascular evaluation and so forth. You can write down the entire history. And then this is the past medical and surgical history, then the diet, then the family history, then the occupation, the marital status, children, tobacco use, alcohol use, caffeine use, exercise, and then the review of system. Okay, the review of system, you write down cardiovascular system. If the patient has not reported anything, you can just do this. And if they have reported something, then you click on this one and write down whatever he accepts, and blank out those, just highlight those that he didn't accept and delete them, and so on and so forth. We go through all these systems. Okay, so this is exactly according to our questionnaire. Whatever you see in the questionnaire, this is the same order, right up to the last menstrual period. Of course, that's only in women. And last pap smear, last mammogram, these are all eliminated for men, but in women you have to do that. In male, you have to do this one. Then you go to objective. In the objective, the entire exam is entered here. And you can do the general appearance, well-nourished, and you can go through all the exam similarly. And you can go one by one and do the entire exam, whatever you did. And in the assessment, now you go and write down patient is stable, or patient is not stable. Here you put the diagnosis. So you go to diagnosis, and then you put down record, and then put down whatever diagnosis, coronary artery disease, for example, or let's say chest pain. Since we have not found out what the cause of the chest pain, so you can put down chest pain, it is acute or chronic, and you write down today's date and whatever else you want to add, a comment or so, and you save it. Then you add on record, high blood pressure, essential hyper. So a lot of these diagnoses are already there, and you save it, okay? So you see this is populating the diagnosis. You record. Another one is that you have aortic stenosis, okay? Or you have bifasical unspecified atrial fibrillation, abnormal electrocardiogram is another common one. Okay, so add all that, and then you go to the plan. Now in the plan, there's nothing entered here, so go back. If it's nothing is there, then you can pick up plan from here, and you can put down the plan. Continue same medications, laboratory studies, low sodium diet, low cholesterol diet, daily physical activity, and then you can put down the patient had a chest x-ray, two-dimensional echo was ordered, treadmill stress test was ordered, chest pain advice was given, what to do if he has chest pain, and or diet for lowering the lipids, sleep study, electrocardiogram, whatever you did, you can put down. Nitroglycerin spray was started, and you save it. And that's it. This is all that is done, and you don't have to sign it yet because I'll be signing that. You just save it here, and once it is saved, then I'll pull it up, do my additions, and then we'll sign off on this one. Okay. So this is how we did a whole history and physical of the patient. Other alternate ways of doing it are there, and I will let you know in the next lecture if there are any other ways to do it. But this is to do the new patient cardiovascular consultation, starting from zero. I mean, there was nothing there. We just did it all with the templates, some with a little typing, especially the narrative part, which is very important. So remember now, the narrative part is the main part that requires your input, where you put down more details about the patient's chest pain. Remember, pain, you have to put down the location. When did it start? How long it lasts? What brings it on? What relieves it? And where does it radiate? Things like that. Shortness of breath after how much exertion? Minimal exertion, moderate exertion, severe exertion. What brings on the shortness? So is there any orthopnea? That is shortness of breath on laying flat. Is there any paroxysmal nocturnal dyspnea? The patient gets up in the middle of the night, short of breath, gasping for breath. So this is how we record that. There's pedal edema. All these, whenever you have a cardiovascular patient, then remember that the whole review of system, you should do it as part of your narrative. Let me explain. So patient comes in with chest pain. So you ask everything that is related to the cardiovascular system in the chest pain symptom. So if he finishes his description of the chest pain, then you do what is known as, you try to evaluate his risk factors, for example. So you do that by asking him about shortness of breath, palpitations, dizziness, passing out. Has he been to an emergency room with the chest pain? Has he been admitted with the chest pain? Has he had a stress test? And how long ago did he have the stress test? How many years ago? Did he have an echocardiogram? How long ago? Who did it? Was any abnormality found? Did he have a heart catheterization in the hospital? Which hospital? Who did it? Where is the report? Does he know? Does he have a diagram? So you see, you can probe into the patient's cardiovascular history right at the beginning and write down all of the narrative. The other things are just to add on and to put more meat into the narrative. You add on, he doesn't have rheumatic fever, he doesn't have history of deep vein thrombosis, he doesn't have hypertension, or he has hypertension, doesn't have diabetes, whether it's insulin dependent or not, does he have sleep problems, sleep apnea, all those things can be added on. And in the end, in the templates also, you see cardiovascular risk factors. So you add down cardiovascular risk factors are number 1, 2, 3, 4. And that's important because that gives you an idea about what the risk factors are. And finally, why was the patient here? Was he here to just assess him for cardiovascular evaluation, or was he here for surgical clearance? That template is also there, which I showed you in the beginning, in the subjective part. There are all these templates that you're adding. And so remember, in addition to the narrative, the template should always be added on to give it a little bit more volume to the narrative. So that's all I want to say for right now. And then, so this will be my third talk in the series of teaching tapes, teaching videos that I'm making. and you all can, one by one, you all can listen to it, to revise it. That hopefully will help you when you get your residencies, and because the structure might be a little different, but the basic principles are the same. Whether you do it in the hospital, emergency room, whether you're a surgical resident or a medical resident, or you are in your practice later on, you'll mostly be doing mostly all your life. That's what we do. That's what I've been doing for last many years. Thank you very much, and hope you have a good day.